It's really a pleasure to speak to you this morning, and I hope that from this lecture you'll have a better understanding of the features of intracranial hypertension and intracranial hypotension, that is, increased pressure and decreased pressure in the brain. And of course, this is something that neuroradiologists face every day in the reading room, and our neurology and neurosurgery colleagues face up on the ward. So it's a very important topic. So let's see here. Go forward. Okay, so we're going to focus most of our talk today on idiopathic intracranial hypertension and spontaneous CSF leak causing hypotension. But just remember, of course, the most common causes of intracranial hypertension are those that we see every day in the trauma unit, that is, patients who've been hit by cars and have bleeding, or have a tumor, or a hemorrhage, or hydrocephalus. And then there are those less rare but very important causes of intracranial hypertension related to the venous side of arterial anatomy and capillary and venous anatomy. And these we always have to keep in mind because these are treatable causes of intracranial hypertension. And here we're talking about intracranial thrombosis of the dural sinuses, arteriovenous fistulae, and a mass effect on the sinuses, such as we see with a meningioma. And then on the other side of the equation, low pressure can be caused by traumatic leaks of cerebral spinal fluid. Remember, cerebral spinal fluid bathes the brain and the spinal cord. The brain floats within CSF. And if we lose too much CSF, more than we're producing, we can then have intracranial hypovolemia, leading to pressure decrease. We can do this idiopathically by shunting patients, over shunting and causing intracranial hypotension on an idiopathic basis, on an iatrogenic basis. And very rarely someone can, of course, have reduced total body water leading to this. But we're going to spend most of our time talking about spontaneous CSF leaks. And this is something you may see, or if you haven't, you've probably missed, because it's increasingly common and recognized in the emergency department as a cause of postural headache. Okay, Martin, is this something that I can move out of the way? Okay, so, okay, now I'll keep you up at the upper corner. Okay, so remember, imaging, what we do every day, does not measure pressure. And unfortunately, that would be a great advance if we could actually measure pressure with MR or another tool, but we don't, because we are not unable to appreciate whether a pressure is normal, up, or down. But some of the manifestations of elevated pressure on imaging, secondary imaging features, are effacement of the sulci, of the ventricles, and of the venous sinuses. And as we'll see, there's a relationship between the CSF and arterial and venous anatomy. One goes up, the other goes down. One goes down, the other goes up. And here we have a patient with increased intracranial pressure. And in fact, you can't see any of the normal, this is a sagittal MR. You can't see any of the normal cisterns around the brainstem, the fourth ventricles, the face. We don't really see the transverse sinus or sagittal sinus very well. And these are features of increased intracranial pressure. Papilledema, of course, clinically dilated optic nerve sheaths on imaging. Now, features of low pressure can look sometimes very similar, except that instead of effacement of sulci and effacement of sinuses, we're going to see enlargement of sinuses, enlargement of the vessels, because they reciprocate with the CSF volume. So if we lose CSF volume, something has to take its place within an intact skull, and what we'll see is the first attempt at doing this is dilatation of the arterial and venous structures, the veins being more obvious, and so we may see very prominent veins like we see here, or normal veins, in a patient who's got effacement of the cisterns. We already see descent of tonsils here. And if you'll notice very carefully, you see also the third ventricle, the floor of the third ventricle is drooping over the dorsum cella, much like we see in the case of intracranial hypertension, but this is low pressure, not high pressure. And then very quickly after that, we'll see enhancement if we give contrast of the dural sinuses. Again, this is because of venous engorgement. So we may see high or low tonsils as well, depending on how much volume is lost. So we don't measure pressure with imaging, but we can infer it sometimes from these subtle findings. Now let's turn our attention to intracranial hypertension on an idiopathic basis. This is sometimes referred to as pseudotumor cerebri. It's fairly rare, but we see it more commonly in women, and in particular in overweight women, in women who have body mass indices of greater than 30. And the cause of this is unknown. Some people have suggested that there's systemic illnesses that have been reported with IIH, such as sleep apnea, hypothyroidism, and a number of other things you can read here. But there's no definite causative factor, and there has been association with some of the medications listed here, including oral contraceptive pills. But be that as it may, we don't understand why this occurs, and in fact, it's an interesting area for research. One of the things we have to make sure is that we've excluded the treatable causes of intracranial hypertension, as I mentioned, venous obstruction and AV fistula. So our role as radiologists are really looking at this and saying, could this be a cause of this patient's intracranial hypertension? She has papilledema, headaches. She's seen in the headache clinic, and we need to make sure that there's not a treatable cause before we say that she's got pseudotumor cerebri or idiopathic intracranial hypertension. Now, there are criteria for the diagnosis of this, including headache, nausea, vomiting, transient visual obscurations, and most importantly, papilledema. The patients should not have any focal neurologic signs, except on occasion sixth nerve palsy, which can be either unilateral or bilateral, probably caused by compression of the sixth nerve as it courses up along the clivus. The CSF opening pressure, as measured in the lateral decubitus position, and you should always measure the CSF pressure if you're doing a lumbar puncture in the lateral decubitus position, needs to be greater than 25 centimeters of water. Remember, normal is between 6 centimeters and 20 centimeters of water. So if somebody had a 22 or 23, we wouldn't necessarily think that was abnormal. But when they get up to 30, 40, 50, even 70, this, of course, is very abnormal. And the scans should be normal. That is, including MR venography, the patient has a normal MR scan of the brain. The complications of this are the most important thing to keep in mind, including blindness. Blindness is the thing that we really worry about. Of course, headache is no fun to have, but we don't want to be blind. And so here's normal, and here's a patient with intracranial hypertension in which the optic disc, we're looking at the back of the retina now, and this is the normal optic nerve disc with the radiating arteries and veins coming out of the optic nerve disc in a normal situation, and you can see in an abnormal situation this sort of starburst. This is papilledema, where we have absence of some of the veins, and of course spontaneous venous pulsations, if you're looking in there, would be dampened. And these are patients who are emergencies because they will lose vision. Now, I mentioned that this is seen in obesity. It's rare in pre-pubertal obese girls, which is sort of interesting. Why that would be, who knows. It's 10% of patients are men, so it's not all women who are affected. And vision changes are worse in African Americans, and I presume in Africans, compared to Caucasians for some unknown reason. We don't know why. I don't know whether that has anything to do with where people deposit fat or if there's any sort of other racial component here. On the other hand, it has been noted that vision changes are worse in patients of African descent, which you might find valuable. Moderate weight gain, that is 5 to 15% of weight gain, is a risk factor even in patients who are not considered morbidly obese, that is with a BMI of less than 30. So a rapid weight gain seems to have some component that may cause intracranial hypertension. And that moderate weight gain might also be a risk factor, particularly for recurrent disease. So once patients lose weight and actually have IIH under control, if they have then a recent weight gain, they can have a recurrence. Now, what do we see at imaging? And I'm presuming that that you have seen some MRI scans and that you know what this looks like. This is, of course, a T2 weighted image, and this is an MR venogram, and here's a CT scan. And so what we may see is flattening of the posterior globe. This is the counterpart of papilledema. We may see increased CSF around the optic nerve itself. The optic nerve sheath is dilated. And this can be tortuous such that it varies in its course in the craniocaudad or superior inferior dimension. It's like it's an enlarged structure as well, fit into the back of the globe, and it kinks. So we may see tortuosity of the optic nerve sheath. Over time, one can see empty sella or partially empty sella, that is CSF permeating down into the sella turcica. And what's very interesting is that it has been shown that in these patients, particularly those who are symptomatic, may have a stenosis or at least a compression of the transverse sigmoid sinus at the point at which a tachyonian granulation typically occurs, right before the sigmoid sinus. So here you see a lateral view of two transverse sinuses. Here's one, here's the other. Here's, of course, the sagittal sinus. You know, the internal cerebral veins, the inferior sagittal sinus, the vein of Galen, the straight sinus, and here's the transverse sinus compressed bilaterally. And it has been shown that people can sometimes have an increase in extraventricular CSF spaces as well. So here's an MR scan, and we see an empty sella. We see downward descent of tonsils. Now, normally we don't think of intracranial hypertension as causing changes in the ventricular size or the tonsils, but it has been shown at Emory University through a nice paper by one of our ex-fellows that in fact this does occur in some patients, so that downward descent of the tonsils may occur. You always want to think about the possibility of a CSF leak in this situation, however. And here we have obstruction at the foramen magnum causing CSF obstruction and resulting in a serrings of the cervical cord. So we know that this is a risk factor for people with Chiari malformations, acquired Chiari, or in this case, downward descent of the tonsils. Okay, so those are some of the features. You can see this person had an opening pressure of 48. This person had an opening pressure of 50 centimeters of water. Yet the ventricles and the tonsils look relatively normal, which is rather typical, frankly, with IIH. You can't really look at the scan and say, oh, that patient's got increased intracranial pressure, because the pressure is equivalent throughout the subarachnoid space and the ventricles, and therefore there isn't a shift. Here's just another example, and this is very, very interesting, and no one really has explained this very well to me. I've noticed it myself, the stenosis of the transverse sinus occurring oftentimes in patients who are deteriorating with their vision. And what's fascinating is that if you do a lumbar puncture and either take off a lot of CSF or do a shunt, this, as you can see in the post-LP shunt, changes. So this is a dynamic process occurring not because of the thrombosis of the transverse sinus, but because of some pressure differential that's occurring in the brain or in the tachyonian granulations. We don't really understand this, but this can be relieved simply by taking CSF off, either through a lumbar drain, a lumbar puncture, or in this case, a shunt. And I've seen this in my own experience as well. And patients can then suddenly have their vision return. Now, this has led, and we'll see later, to interventional therapy where a stent is placed in these transverse sinuses. And this is gaining traction in the interventional community. It doesn't really address the precipitating factor. We don't know what that is, but in these patients who have vision loss, they have stenting of the transverse sinuses being done now. This is a nice paper that was written by Noah Alperin, who has spent a lot of time looking at CSF pressure. And what he found in these patients is an increase in CSF outside the ventricular system compared to controls. So here's normal on the top line and the patient with intracranial hypertension on the low line. And he found a statistically different amount of CSF extraventricularly. We don't know why that occurs, but perhaps it has something to do with a reduction in CSF absorption or some other factor. Don't know. Okay, the treatment. I mentioned weight loss, of course, is the easiest thing. Maybe not the easiest thing, having been on that side of the equation. It's not so easy to lose weight or to keep it off, but that would be one factor that would be the first, less interventional factor, diamox being another. I mentioned lumbar puncture and shunting, transverse sinus stenting, and then in those who are going down in vision, there is optic nerve sheath fenestration. So this is a view of the optic nerve here and papilledema that's occurring at the back of the globe, and the ophthalmologist will go in and make a cut in the dura, allowing CSF to escape that dilated optic nerve sheath, and this is called optic nerve fenestration. Okay, stenting for transverse sinus. There's a number of studies that are now out there. Here's one that is from 2015, as sort of a meta-analysis, a review article looking at 185 patients in 17 studies. They found that the mean pre-stent pressure gradient over that stenosis was 20 millimeters of mercury, and then after stenting it dropped to 4. Complications were rare, and patients who had this physiologic gradient got better, and venous stenting appears to be safe. So this suggests that this is an option for those who are recalcitrant to the usual therapies. Now, let's not forget the other causes, and here's a wonderful example of the use of MR imaging in a patient who presented with headaches. In fact, this was postural headaches. Initially, the clinician thought that she had postural headaches because of intracranial hypotension, but when we measured her pressure, we found the pressure was 40, not low, and we looked carefully at her scans, and this is a very subtle scan. You can see that it sort of looks normal on the contrast study here, the gadolinium study, but in this arterial spin labeling, we see that there's a mass with high blood flow at the cranial vertex, and if we look carefully at the MR venogram, we see that there's some narrowing there. And this is a meningioma that we knew that she had other meningiomas, but this is a great case of a small meningioma up at the parasagittal location, causing compression of the sagittal sinus, resulting in intracranial hypertension on a venous basis. And you can notice that she doesn't have the typical features in the transverse sinus of intracranial hypertension, like I just showed you with idiopathic hypertension. And down below is an interesting example of a person who's got this sort of irregular margin of the transverse sinuses. You all see that? It's not smooth. There's a little enhancement here. The patient has a fistula. This is an arteriogram, external carotid arteriogram, and we see a filling of the transverse sinus very early by branches that are fistulizing the transverse sinus, causing intracranial hypertension on a AV fistula basis. So these are the things that we want to exclude before we make the diagnosis of intracranial hypertension on an idiopathic basis. Okay, and here's a patient with headache and papilledema secondary to thrombosis of the transverse and straight sinus. And this can be a tough diagnosis, very easy to miss. particularly on a CT scan. So if you're looking at a non-contrast CT scan, your eyes might be drawn to these hypodensities in the frontal lobes. And these are, this is edema or maybe very early venous infarction caused by intracranial venous hypertension, but the pathology is back here. And here's another little down. You might say, oh, this patient's got vasculitis, or perhaps the patient has some arterial disorder, what have you. But in fact, the diagnosis is made here, where we see the sagittal straight sinus, rather, is too dense, and also the transverse sinus is too dense. So this is a patient with thrombosis of the transverse and straight sinus causing intracranial hypertension on that basis. So beware of that. It's tough. And of course, this can then lead to hemorrhagic infarction. So if one sees a subcortical hemorrhage in the temporal lobe, like we see here, we want to always think about the possibility of thrombosis of the vein of Lebet that drains into the transverse sigmoid junction and can give rise to edema and ultimately hemorrhage in that area. Okay, so that's the diagnosis of intracranial hypertension. Our role is to exclude the treatable causes of that entity. We may be called on to treat the patient with a lumbar puncture, or if you're an interventionalist, by a transverse sinus stent. Now let's turn our attention to the opposite spectrum, that is low pressure syndromes. And I mentioned a number of them, but we're going to concentrate on spontaneous CSF leaks. And this is often caused by a spontaneous rupture of the dura, or either because of a connective tissue disorder, a disc herniation, or a rupture of a perineural cyst. And there may be other etiologies we'll talk about as well. So in this entity, the patient is typically aware of the onset, sometimes abrupt and sometimes gradual, of a bad headache. And they come to the emergency department or to their doctor complaining of a headache. And with questioning, they realize that the headache is worse in the upright position, and it goes away when the patient goes to bed. And then they get up and it hurts again. And so this is so-called postural headache. And here you see some of the classic features of intracranial hypotension that is due to a CSF leak. We have downward displacement of the tonsils. We have flattening of the pons in the sagittal plane. Notice the third ventricle again. The third ventricle, the floor of the third ventricle is drooping down over the dorsum sella, something we do not see with Chiari 1 malformation. And in the investigation in the spine, we see this collection of contrast on the myelogram outside the dura, spiraling up like a dissection. And if the pressure differential is very low, one can see spontaneous subdural hematomas or effusions because of blood being pulled out of those vessels that are next to very low CSF pressure. Okay, so this is a result of a loss of CSF volume resulting in a postural headache syndrome, typically. It can occur in all age groups, but we see it often in middle-aged females, usually caused by a fistula, a CSF fistula that is a hole in the CSF, oftentimes at the cervical thoracic or thoracic level. And I mentioned the causes here. The pressure is low. Remember, the normal pressure is between 6 and 20 in the lateral decubitus position. These patients often have low pressure, even below 6, but they could even have a normal pressure. It's just that normal for them is higher, and they may go down to 8 being normal, but they normally run at 15, and so a normal pressure doesn't exclude this diagnosis. And the imaging is diagnostic, but can be very subtle, and MR is better than CT in making this diagnosis. So we often will be called on to try and sort out if there's a leak, where it's located, and treat this with a blood patch. And the blood patch is curative in usually about 3/4 of the cases. You may have to do 2 or 3 blood patches depending on how big the leak and where it's located. Okay? So an important concept is the diagnosis of Chiari 1 malformation requires you to consider an alternative diagnosis of intracranial hypotension, spontaneous intracranial hypotension, before you assign this diagnosis of Chiari 1. Otherwise, the patient will go on to a suboccipital craniectomy for Chiari 1, but in fact needs a blood patch rather than an operation. And here's just one example of a little girl who is now 15 years of age. This is when she was 8, and she'd had a suboccipital craniectomy, you can see here, for Chiari 1 malformation, but notice her third ventricle is drooping over the dorsal cella. And she had headaches from the age of 2. Here is an example blown up of her third ventricle. Notice the mammillary bodies are almost kissing the pons. This should be about 5 to 8 millimeters in distance. And she also had a syrinx and had this very odd appearance of her lumbar spine, sort of fat replacing the normal lumbar spine, which we didn't quite understand until we did CT scans and a myelogram because of that role. And we see here that she has a fistula. This is with a needle placed in the fecal sac. She's prone, and you see an immediate fistula between the fecal sac and, in fact, the L4 nerve root and this paraspinous and intraspinal vascular lymphatic malformation. This is a patient who has vanishing disease of Goro, very rare disorder where the bone is eaten away by a sort of hemolymphatic malformation, but it can then erode into the CSF. So this is a rare case. We've reported this. The only reason that I'm pointing it out is that we'll see some of the spontaneous causes of intracranial hypotension indeed have been are caused by a fistula between the CSF and vein. And remember that the vein is very close to the nerve roots and and as they exit underneath the pedicle, and so we believe that that can also be a cause of CSF hypotension. Okay, so let's take a step back and remember what's inside the intact calvarium. And the intact calvarium has a brain that's normally outside the skull, weighs 1,400 grams, but if you place it in water or CSF, it only weighs 50 grams, so we float. Our brain floats in CSF. There are vascular structures, there's arteries, there's veins, and there's cerebral spinal fluid that bathes the brain and the spinal cord. There's about 250 cc's in the brain and spinal canal. In the spinal canal, 50 to 75 cc's, intracranially 150 or so to 200 cc's. Normally, we produce 0.3 milliliters of CSF per minute, or about 500 mLs in a 24-hour period. So that means that we, as human beings, turn over our CSF volume at least twice, sometimes 3 times in a 24-hour period. So we're producing CSF, it's being replaced, and it's also being taken up by the veins along the sagittal sinus, the dural sinuses in the spine, and probably elsewhere. I mentioned the opening pressure, and when you are upright, the pressure at the vertex up top can be a 0 or less. Okay, so it is the case that our pressures change with different postures, and this is an important concept to keep in mind. Now, if you take out 10% of the volume, so around maybe 25 to 30 cc's of CSF, that typically will cause a headache in patients. And this is studies that have been done in experimental situations. Okay, so just remember what the floor of the third ventricle looks like. It's kind of at a 45-degree angle. It doesn't droop over the dorsal cella. There's normally CSF and a little space for the basal artery between the flavus and the pons. The cerebellar tonsils are typically at or just below the foramen magnum, and we'll see CSF in the foramen magnum and the cisterna magna. So these are some of the normal relationships. And then as the CSF volume decreases because of a leak, something has to take its place, and that's easiest done by increase in blood volume. But if that doesn't suffice, then we start getting into